We are Team D Sharps, and we will be presenting a talk on HHS, also known as hyperosmolar hyperglycemic state, what it is and how it is treated.
HHS is a metabolic emergency that arises as a complication of type 2 diabetes. It's characterized by increased blood glucose levels in the absence of ketoacidosis. HHS is most common in older adults with type 2 diabetes. It can also sometimes be seen in children, but we'll be focusing on the adult presentation for this talk.
There are several causes that precipitate HHS. The most common causes are non-adherence with diabetes medication and physiologic stressors, especially infections such as pneumonia, UTIs, and sepsis. Other stressors include pancreatitis, MIs, and CVAs. Finally, another important precipitating factor of HHS is medications such as diuretics, corticosteroids, and antipsychotics.
When a patient has HHS, she might complain of a few of the following symptoms: increased urination, increased thirst, significant weight loss, weakness, or mental status changes noticed by the patient herself or those around her. The important thing to remember is that symptoms are similar to those in DKA, but with a slower onset. When assessing a patient with HHS, there are a number of possible signs, but these may or may not be present. The key thing to notice is signs of dehydration. In other words, with vitals you might find that the patient is tachycardic, hypotensive, and the patient may have poor skin turgor.
The American Diabetes Association has specified a number of criteria to make a diagnosis of HHS. The key point to remember is that HHS occurs within a context of very high plasma glucose levels, usually above 33.3 millimole per liter, and that pH and serum osmolality will also be high.
In patients with relative insulin deficiency, HHS is often precipitated by physiologic stress. Recall, for example, acute illness. The stress increases counter-regulatory hormones to insulin, such as glucagon, catecholamines, cortisol, and growth hormone. These hormones increase gluconeogenesis by activating required enzymes and creating gluconeogenic precursors.
Generally speaking, there are three main mechanisms that together cause hyperglycemia in HHS. 1. Impaired glucose utilization. 2. Increased glycogenolysis. And 3. Increased gluconeogenesis. These processes create a state of hyperglycemia, causing a shift of water from organs, such as the brain, into the bloodstream. High plasma osmolality and lack of normal osmotic return of water to the blood by the renal tubules lead to polyuria and osmotic diuresis. This in turn leads to a decrease in blood volume, impeding the kidney's ability to excrete glucose, and thus a vicious cycle begins.
As previously discussed, people with HHS are often dehydrated due to hyperosmotic diuresis. Therefore, a mainstay of treatment is IV fluid resuscitation. Depending on the level of dehydration, infusion rates of normal saline are modified from the recommended starting rate of 15 to 20 mL per kilogram per hour. Potassium is often low in HHS. However, potassium replacement should not be started until urine output reaches a volume greater than 50 mL per hour. Once replacement therapy is started, the goal is to maintain a level of potassium between 4 to 5 milliequivalents per liter.
Once potassium rises to levels greater than 3.3 milliequivalents per liter, insulin therapy is used to address hyperglycemia if it was not already normalized during IV fluid resuscitation. The rationale for normalizing potassium levels before insulin infusion is to prevent precipitating any life-threatening arrhythmias. If you recall, insulin shifts potassium into cells, so any pre-existing hypokalemia would be further exacerbated with insulin infusion. Insulin therapy will be discussed further on the next slide. Low phosphate and low magnesium levels are also common electrolyte imbalances seen in HHS. However, there is no evidence to treat these imbalances unless the HHS persists beyond the acute phase. At that point, phosphate and magnesium replacement therapy should be initiated.
After ensuring adequate urine output and serum potassium levels, give insulin. Administer a bolus of 0.1 units per kilogram of regular insulin. Continue with 0.14 units per kilogram per hour IV continuous regular insulin infusion. If serum glucose does not fall by at least 10% in the first hour, administer an additional bolus of 0.14 units per kilogram. After the blood glucose falls below 16.7 millimoles per liter, reduce the infusion rate to 0.02 to 0.05 units per kilogram per hour. Maintain the blood glucose between 11.1 to 16.7 millimoles per liter until the patient becomes alert. Check the patient's electrolytes, BUN, creatinine, and glucose every 2 to 4 hours until stable. Once the patient is able to eat, start subcutaneous insulin while continuing the IV infusion for 1 to 2 hours to ensure adequate serum concentrations. Heparin should be administered, unless contraindicated, to prevent thromboembolism. Consider extended prophylaxis for higher risk patients. Consider prophylactic antibiotics if infection is suspected, or treat the precipitating factor.
So in summary, the main take-home points regarding hyperosmolar hyperglycemic state are: HHS is a medical emergency in type 2 diabetic patients. Dehydration is a key physical exam finding. And treatment is focused on rehydration through restoring fluid electrolyte balances and reducing serum glucose levels. Insulin treatment should be initiated if needed once fluid electrolyte levels are restored.
Dynamid and UpToDate were used as our primary resources for information. PubMed was used to search for additional information, verify sources, and find clarifying detail. Wikipedia was also used to ensure that there were no other broad topics that were missed. On the following slide, we have also listed our references.